Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by AACN's Career Center, offering career resources, free resume reviews, and personalized job alerts, with information available at www.aacn.org/Career Center. Now, here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Hi, this is Andrea Schmidt, and welcome to the Voices in Nursing podcast. I am joined today by one of AACN's guest hosts and our nurse content strategist, Brandy Pack.
Hi, Andrea. I'm so excited to be here today.
For all of our listeners out there, we are going to be talking about pregnant patients in the ICU. And we know that when we hear those words, that strikes fear in all of our hearts. It increases our heart rate. We care for patients at every stage of life, but this probably is one of the scarier ones. And critical illness in pregnancy is really becoming more common, Brandy. These patients can bring very unique challenges, and they may arrive critically ill while they're pregnant, or they may have a postpartum issue, or pregnancy may complicate an existing condition.
I'm sorry, but either way, there's two patients coming into your ICU. So
exactly.
I feel like sometimes they just roll up and you're like, okay, just go. Good luck to you. The good news is though, people like Julie, the right knowledge, strong partnerships, and a clear plan, ICU nurses can provide that competent, compassionate care that supports both mom and baby.
Absolutely. And we need people like Julie. So today we are excited to welcome Julie Kruithof. She is from Corewell Health in Grand Rapids, Michigan. She is an award-winning critical care educator, and she has a career-long passion for AACN and for obstetric critical care. So she sounds like she is the go-to gal. But Julie, before we dive in, would you please introduce yourself to our listeners and share what pulled you into this particular work and made obstetric critical care such a passion for you?
Well, thank you for inviting me to this podcast. I think this is very exciting, and I love OB critical care. I've been in critical care my whole entire career. I always joke with my learners that it was Florence and I at the bedside. So we have a long and storied history. But we saw a really big need in our institution to develop some really great plans of care and really enhance nursing education for OB patients, because we were seeing them postpartum, intrapartum, antepartum, the whole realm. And so it just became one of those little niches. And the more I learned, the more I was just fascinated by how impactful the physiologic changes are and how important the partnerships are and how important really having a solid plan was in order to really optimize care for the patients. So we've seen a lot of different patients, and I have just fallen in love with the whole OB critical care topic.
Wow. At least somebody has, so that's just amazing. Now is Cornwell, is there just a lot of more pregnant people there? Like, why is there so many? Is it just in that area in Grand Rapids?
A tertiary care center, and we're a level 4 maternal level of care designated center. So we do care for the sickest of the sick throughout West Michigan. So we do see a lot of very unusual cases. We also have a big cardiovascular presence. And so we get a lot of women who have cardiac disease who come for referral and so forth, for the heart and lung transplant center. So we also see women with peripartum cardiomyopathy who then don't recover, but then need to progress to transplant. So we see a lot of very interesting issues.
Wow. Well, okay. One of those patients just rolls up into your ICU. Let's just start there. Okay. Your alarms are going off. The team is like, oh my. I heard you use the simple framework though, called the 3 Ps. So physiological change, partnership, and plan and priorities. It does kind of sound like 4, just saying it. But this does help those teams can be grounded. So can you give us like a high level overview of those 3 Ps, and then we'll kind of break them down and just explain why this framework works for you and works for those ICU nurses?
Absolutely. We do teach a component of obstetric critical care in our critical care curriculum. And so I wanted something that was really easy for nurses to remember. And I am a huge penguin fanatic. And so the letter P just worked out great for me because I could use it on all my slides and have penguins in the background and so forth. So,
Awesome.
but understanding the physiological challenges and all those changes is really paramount for very safe and effective care. Pregnant women are different. Anyone who has experienced pregnancy understand that there are changes and you are not the same when you're pregnant as you were before or after. So those physiologic changes just really are essential. And as critical care nurses, we know a lot, but most of us haven't thought about obstetrics since our first clinical rotation in school. Let's just be honest. It's like, no, we don't do that. So partnering with those obstetric colleagues is really essential to provide optimal care. Pregnancy and birth are supposed to be very natural and normal. So experiencing critical illness during the time just elevates the concerns, the stress, the fear for everyone, for the patient, the family, and the healthcare team. And that's where that third P comes in, is really having that team develop a really solid plan and knowing what the priorities are so that we can really provide really effective care.
I think that all makes perfect sense. And really, we all need each other. It's got to be such a collaborative effort because, you take your nurses and doctors with that level of experience, they're going to help guide the care. There's always the joke in ICU. We care from the head down to, the abdomen, and then in between the abdomen and the legs is all OB, and then everything below is ICU again,
Absolutely.
But
Absolutely.
this is why we have our experts. And so I do want to talk about the physiologic changes, though. Myself being a critical care nurse as well, and I think about, pregnant patients and how what is a normal vital sign or normal ABG or normal assessment in a non-pregnant person becomes abnormal, right,
Yes.
in that patient. So let's say they come in, they have sepsis or trauma or maybe a pre-existing pregnancy condition, at a high level, what are those physiologic changes that ICU nurse should really watch out for when they're caring for that patient? And I think the other piece is too, everybody's very worried if they're pregnant, we don't want to harm the baby.
Yeah. And that's a great thing to be worried about because everything that we do is going to have an impact on the mom, but everything we do that has an impact on the mom is going to have an impact on the baby as well. So we definitely want to keep both in mind. From a physiologic changes perspective, one of the basic things is that their blood volume is going to increase about 1.5 to 2 liters. And in order to accommodate that volume, peripheral resistance is going to decrease. So you have to have a bigger vascular space in order to put all that extra blood volume. And stroke volume and heart rate are going to increase. And so we always think of pregnancy as a high output, low resistance state. Because of that extra blood volume, development of an S3 or a systolic murmur may occur, but those are considered pretty physiologic in pregnancy. And the other thing to keep in mind is pregnant women are hypercoagulable. This is a defense mechanism in order to not have them postpartum hemorrhage when they deliver. But if you think about the reduced mobility sometimes that our critical care women have and so forth, that hypercoagulability can also lead to issues. From a pulmonary perspective, both the AP diameter and the respiratory rate are going to increase. So they have an increased minute ventilation. Their oxygen needs are higher because they are supporting that fetus for the growth and development as well. The gastroesophageal mechanism, so that's that lovely little sphincter between the esophagus and the stomach, that becomes incompetent. So everybody says, well, yeah, that's why all the pregnant women have heartburn, which is true. But for us as critical care nurses, the heartburn, okay, but really that equates to a really high aspiration risk. And that's something that we need to be very cognizant of, especially when we're intubating people or concerned about their airway. All their mucosal tissues are very hyperemic. So anytime we're going to do oral care or do any kind of intubation with mucosa or put a Foley catheter in, those mucosal tissues are very fragile and they could easily bleed. So we want to keep that in mind when we're caring for them as well. And from a renal perspective, renal clearance is definitely enhanced because of that increased volume and cardiac output. Renal clearance of medications and substances and so forth normally is very enhanced. So I would say those are some of the big things that we would want to keep in mind.
Yeah, it sounds like those physiological changes of pregnancy are enough to make it look like that patient's already sick without a baby. Like, I just can't imagine having somebody with just a little extra volume just hanging out, no baby. So are there like other things like heart rates or vital signs that may look different that like an ICU nurse would just like get totally tripped up on, like this patient's heart rate's way too high, something's wrong, when in reality it's just more fluid and
Definitely. There are some definite things to keep in mind from a numbers perspective, because, we always look at our numbers. One of my favorite statements is that the physiologic changes of pregnancy are so significant that if they occurred outside of pregnancy, we would consider them pathologic.
oh man.
So if you think about like the S3 or the systolic murmur development, inside of pregnancy, it's considered physiologic. But if that happened outside of pregnancy, we would be concerned because that was a pathologic change.
Yeah.
So those things you really have to keep in mind. Unfortunately, that's also sometimes why things get missed, because maybe a change is dismissed as physiologic, but there's actually something more going on behind it. And
So this isn't like all
exacerbated.
pregnancy. Like not just sick pregnant people. Like that's all
Oh,
pregnant
that's
people?
just baseline pregnancy. Yeah.
Oh my goodness
Yeah.
gracious.
Right. Absolutely. Because that woman has to be able to not only support her own metabolic demands, but also the metabolic demands of that growing fetus. So some specific examples. So pregnant women tend to have a dilutional anemia. So our goal is to try to keep their hemoglobin above 10 because their blood volume increases, but the volume increases more than their red blood cell percentage. So they end up getting a dilutional anemia. So we try to keep their hemoglobin above 10 is a really nice target. Cardiac output should be at least 6 liters a minute, and that's pretty baseline. And most of the time, we don't index their values. We're very used to saying, "Oh, okay, with their cardiac output, but what's their cardiac index?" We don't do that because that's based on body surface area, which is based on height and weight, but their weight changes all the time. So it's not as reliable of a number. So we usually just go with base cardiac output. If you think of the respiratory parameters that increased metaventilation, their arterial blood gases are going to be different. They run a baseline respiratory alkalosis. So a pH somewhere between 7.4 and 7.45 is normal, just on the alkalotic side of normal. CO2, 27 to 32, and bicarb is still 18 to 22. And our goal is really to maintain the mom's PO2 between 104 and 108 with an O2 sat greater than 95. And that can be very challenging in a critically ill obstetric woman. Very, very challenging. But all those changes in the blood gases are really important because those then translate to how the fetus can get rid of their CO2. You think of the diffusion gradient and how the mom can pass oxygen to the fetus. So there has to be those diffusion gradients that exist for that placental exchange to occur. So those are really physiologic, but they're also very important for fetal oxygenation and carbon dioxide exchange. The increased renal clearance means that both mild glycosuria, so a little bit of spilling of sugar and a little bit of spilling of protein is normal. If the protein spillage is more than 250 milligrams per deciliter, however, that's concerning. So that's always the threshold for protein spillage. But our key indicators of renal function, like we usually think of our BUN and creat, are very normally low in pregnancy. So a BUN of like around 9 and a creat of 0.5. This is one of the places that I think it's really easy to get tripped up. If your standard critical care patient had a BUN of like 20 and a creat of 1.2, you'd be going, wow, that's like really good. I don't see those numbers very often. But in a pregnant woman, those numbers would be twice normal. And so that could be, those numbers would indicate significant renal compromise. So you really have to think about, but what's normal for pregnancy, especially with things like gases and BUN and creat. Heart rate's going to be a little elevated, stroke volume is going to be a little elevated because we need that higher cardiac output. So those are some of the key things that I would keep in mind.
And this is why we need the collaboration with either the OB or MFM, because I think, your standard intensivist, yes, they may learn it in school too, but if they don't see it a lot, I think it can really, have an impact. It's easy to forget all of that. But I want to ask one more thing, and I know, from the extra blood volume, you're more likely to have some arrhythmias of pregnancy. So can you share what a few of those would potentially look like that may or may not be concerning?
The most common thing that you're actually going to see is just a baseline tachycardia. That's very, very normal and natural that they have just a baseline, very mild tachycardia. Outside of that, there's not a lot of evidence that any like serious dysrhythmias would be considered normal outside of that baseline tachycardia. And that's just to accommodate that extra blood volume and that extra stroke volume. The other thing with that extra blood volume that critical care nurses should keep in mind is that because of that extra volume, our volume replacement has to actually start sooner because their symptoms of hypovolemia will be masked a little bit at first because they're used to a higher volume, so you don't see it at first. So if you do see symptoms of hypovolemia, they're actually very hypovolemic. So you really have to get on top of them early.
That makes sense. Total sense. And, I guess I was always taught, commonly the extra volume could cause, extra PVCs or PACs, but they're not necessarily concerning the way it could be in a non-pregnant person that may have irritability. So is that accurate?
It's mostly just the tachycardia that we see
Okay.
from an ECG rhythm change. Yeah, and that's
That's
just a
good to know.
mild baseline tachycardia, like
Mhm.
just up to like 110, 115-ish, so not significant. If their heart rate's 140, 150, there's still something going on.
Oh,
That's not
that's
normal.
good. Well, that was extremely informative. And so let's move on to the second P, which is really those partnerships. And we've already kind of alluded to some of that. We know it requires collaboration beyond the usual team. So besides the intensivist and the OB, who else should really be involved earlier than later?
Yeah, that's a hard question because so much of it really depends on exactly what's going on with that patient. If they're trauma, we need trauma specialties, that type of thing. But we don't know the maternal fetal stuff and they don't know the critical care stuff. So absolutely. And most of them will say, we don't want to know. We don't want to know.
We know what we know. That's good.
We know we're good with what we know. We just don't want the other stuff. So it's really, maternal fetal medicine. So that would be the high risk pregnancy individuals, obstetrics. Neonatal is another key because many of these women will deliver babies who have been experiencing some kind of stress and will need neonatal support. So creating that partnership with neonatal, with the obstetric nurses, whether it's either the labor and delivery people or the postpartum, depending on what phase your patient is, if they're antepartum or postpartum, that whole women's health is really, really critical. Obstetric anesthesia is another one that sometimes people don't think about, but that is really important when it comes to planning delivery. And what are we going to do from an anesthesia perspective? Because that's going to have an impact on the mom and on the baby. So that also,
I would never have thought of that.
Me neither.
Yeah. They are absolutely essential surrounding delivery because maybe it's spinal, but maybe it's general, but it really depends on the mom's, maybe it's just local. And so it really depends on the mom's status and what's going on, what is going to be the best and status of the baby. So they're another really key partnership. And then all of our normal ones you think of women who are going to be maintained in critical care for a period of time, nutrition and all the rehab services so that we reduce muscle wasting and all of those sort of respiratory care and lab and all pharmacy. Oh, cannot talk about how big of a partnership pharmacy has to be. Every medication that we give has to be thought about because every medication has an FDA drug category and they're ABCDX. So you have to know what that category is. And our goal always is to give the woman the highest level medication that has the effect that we need but we really need our pharmacist partners in order to try to figure out, we really want to give this med, but maybe there's one that's a higher pregnancy category that will do the same thing. That might be better. So pharmacy is also a very key partnership.
It sounds like we need a plan and some priorities.
We absolutely need a plan.
That third P, but like what, like the, like Levofed, like, you know, your patient's septic. Can a pregnant woman have Levofed? Like,
So
no, I mean,
Norepi is a category C medication, which means you should use it with caution.
Huh.
So I do very simple categories. I do A's are awesome. B's are better than most. C's are should be used with caution. D's are don't if you don't have to. And X's are extreme cases only. So that's the way I remember the pregnancy categories, because I like simplistic things. So awesome, better than most, cautious, don't if you can avoid it, and X's are for extreme cases only.
That's a great way to remember it.
Well, like I said, I like simple things. That's why I had to do 3 P's and drug categories.
And the penguins.
And the penguins.
But how does the fetal viability influence? Like, do we decide like who the priority is? Is it mom? Is it baby? Maybe both? Like
that is always
nurses,
a very
like,
challenging question.
Think about.
You have to weigh both, and everything that we do takes into consideration that gestational age. Exactly what viable age is still a little on the nebulous side, and different authorities will have different numbers thrown at you, and sometimes your institution will also have an theory about where they are and what they do. But generally speaking, 20 weeks is a pretty good cutoff to use. Obviously, we're always thinking about both lives because both are precious. Before 20 weeks, it's really focused most of our efforts on the mom so that she can get optimized and support that fetus in the best way possible. After 20 weeks, that conversation typically starts to shift a little bit to really considering how to create the best environment for the fetus. Preferably that's in utero, because babies do best when they stay where they're supposed to stay for as long as they can.
They grow where they're supposed to grow.
Yeah. When they grow where they're supposed to grow. That's where babies do best. And if that is not a good environment and it turns into be a toxic environment, then it's probably going to be best for that baby to be in the neonatal ICU, where all their needs can be supported.
But like, how do they get out? I was like, part of that plan is making sure where that baby's gonna come out at. Like, do I have to deliver the baby? I mean,
yeah, and that has to be that's typically a very lengthy conversation with a lot of players involved. Because you have to think about the mom's stability, you have to think about the baby's stability, and people like their own turf. That's all there is to it. You know, OB always wants to deliver in OB. Critical care is like, I really don't want to take this really sick patient on the road.
No.
So exactly where that is. Usually we try to do vaginal delivery. That's always preferred if possible. But cesarean deliveries are, reserved for obstetric or fetal reasons sometimes. And that'll be up to the obstetrician who's involved in the patient's care. But exactly where to do it is up to the team. Sometimes it's in the OB suite, and we mobilize critical care resources, or in the OB delivery room, and we mobilize the resources we need. Sometimes it's in the critical care unit. Typically, if it's in the critical care unit, that's usually an emergent situation.
I was like, that sounds awful. I'm not
with a highly unstable mom, and we don't have a choice but to pull the baby. Most of the times when we do deliver the baby in that situation, moms actually start to do better because they don't have that extra metabolic stress on them. We actually had one patient who we coordinated a cesarean delivery in the cardiothoracic operating room.
Wow. Oh boy.
She was a Marfan's patient, and there was a lot of concern that she was going to experience aortic dissection during the stress of delivery. And so after moving no less than 8,000 mountains and having huge conversations about a lot of advocacy about how are we going to make this happen, we did make it happen, and she actually did great. So we made it her delivery in the cardiothoracic operating room so that if she dissected, we didn't have to move her in a highly unstable situation. We would just be able to crack her chest and rescue her from her aortic dissection at that time.
Now I want to talk about this baby. So cardiac monitoring, cool. Fetal monitoring, that's a little different. So what should these nurses know about fetal monitoring? And like, do you have an easy way to remember what changes should prompt that immediate communication?
So some of the things with fetal monitoring is we're always going to defer to our obstetric colleagues because they are the experts. And, fetal monitoring is really a screening test to assess fetal well-being or their acid-base balance. And interpretation really requires a lot of advanced knowledge and clinical expertise. And just like with ECG rhythm interpretation, it's one piece of that overall clinical picture. So it's a piece and a part of it. It may not be the end all be all. So while I truly support and I honestly say, leave it to the OB people, I think it's very helpful for critical care nurses to have a baseline understanding of what the categories mean, because it might have a huge impact on my care of the mom based on how that baby's doing. So you have to remember that the uterus is considered a non-essential organ, at least from the mom's perspective. From the baby's perspective, I argue that it's essential. But from the mom's perspective, the uterus is always considered a non-essential organ. It's the heart, the lungs, the brains that are her essential organs. And so blood flow is going to be shunted if there are major issues going on and flow needs to be redirected to other places. Mm-hmm. So there's 3 categories that they'll talk about from a fetal monitoring perspective. Category 1 tracings are considered normal. Yeah, yes. Love normal. And those are very predictive of a normal acid-base balance at that moment. Doesn't mean things can't change, but at that moment. And that means that the fetus is receiving adequate perfusion to maintain that normal acid-base balance. Well, for me as a critical care nurse, my brain goes, okay, if the fetus, which is in a non-essential organ, is getting adequate perfusion to maintain acid-base balance, that should mean that a lot of my moms,
right? They're fine.
Essential organs are getting adequate perfusion as well.
Absolutely.
So I love category 1 tracings because that means the baby where it's supposed to be and the baby's happy. And that's great. Category 2 are called, they're considered indeterminate. Like it may indicate abnormal, but could be okay for a short period of time. They require further surveillance, continued surveillance, and probably reevaluation. And if I, as a critical care nurse, hear, oh, they got a category 2 tracing, I'm automatically going to think about, okay, is there something that can be done to help the mom's perfusion of that non-vital organ? Typically, that's called intrauterine resuscitation, which usually is either fluid bolus if she can tolerate it, oxygen via face mask, and it's always going to be about 15 liters via face mask if they're not already intubated, because moms are mouth breathers, so putting a nasal cannula on does nothing. So face mask, 15 liters of face mask, or repositioning. And usually that's to a sideline position, because if they're on their back, that gravid uterus can compress the vena cava and reduce the mom's cardiac output. Oh. So side lying is really preferred. Right or left, whichever she does better is good. And then there's category 3 tracings. Category 3 tracings are abnormal. Absolutely abnormal. Very highly predictive of abnormal acid-base balance, very unfavorable uterine environment, and the infant's really in distress. So category 3s, if I hear the OB nurse like, I got category 3 tracings, I as a critical care nurse should be thinking, oh, this is going to get serious really quickly. Like we might do that intrauterine resuscitation and try that, but probably what's going to happen is delivery. Because the baby's in a toxic environment and they're probably going to be doing better outside than inside at this point in time. So I think it's very helpful to know 1s are good, 2s are like, well, we'll see, and 3s are like, oh, this is not good.
Like we got to move quickly.
Yeah.
I think the good news is what I'm hearing you say though is obviously the OB nurses, the labor and delivery nurses are the experts. Really, they're the
Yep.
ones who should be doing the monitoring.
Yes.
But we can listen and hear what they're saying and kind of get an idea of where this is going.
And I think like with category 2 tracings, it's like, okay, she's not doing a great job perfusing. Is there something like, is there fluids or oxygen or a change in position? Or do I have to look at what her cardiac, did she have a change in her cardiac output that's really making a difference? What's going on? Does she need more pressors? Do I need vent changes? How can I help her change it so that she has better perfusion to that non-essential organ?
I
Like
think
at
that's
that point, you can intervene, you can.
Right. This is what we do. We'd like to fix it.
We like to fix it. We're fixing
Well,
it for sure.
once we've optimized her and you still have that category 3, that's when we're talking about our next phase, of planning is what we're doing with the baby and, how we're going to get it out. And God forbid we've optimized mom and we can't do any more and something happens and she has a cardiac arrest. What are the key priorities that ICU nurses would really need to understand? I know that really they need to be sort of sidelined for that as well, and that includes CPR. But what are we looking at from a resuscitation perspective and delivering that fetus?
Yeah, unfortunately, it does happen that pregnant women do experience cardiac arrest. We're going to use our standard ACLS interventions. So defibrillation's no different, cardioversion's no different, CPR is no different. Like, do good basics. The first highest priority is, you mentioned sideline position, which would be ideal, but it's really hard. You can't get effective compressions in a sideline position. So instead, we'll turn the mom on her back. But then the very highest priority is something called continuous lateral uterine displacement.
Okay.
So somebody be on one side or the other side of that mom and literally move her uterus off to the side and get that uterus off the vena cava.
Yeah, because it's like sitting on it, right? So it's like,
because it's just compressing, and that gravity is just compressing the vena cava, and that is just going to
kind of need that
output. And so we know that even great CPR doesn't do that much for cardiac output. So we need that uterus off the vena cava to promote venous return so that we can have some semblance of cardiac output. So it doesn't matter if they pull it or push it, just get it off the vena cava.
Yeah, because you wouldn't get good recoil if they're laying on their side without anything behind their back, right? But
so
in the event it happens,
with continuous lateral uterine displacement.
That makes sense.
If they have fetal monitoring going on, we typically will discontinue it and get rid of it because we already know how things are going. We don't need a monitor to tell us.
Level 3. Level 3.
We don't need a monitor to tell us things aren't, the baby's not very happy. We don't need that. Many of these moms may have been receiving IV magnesium because that's very common as a seizure prevention in hypertensive disease. So that typically we stop, and usually providers may order calcium chloride or calcium gluconate as a slight reversal for that, because we'll run their mag levels somewhere between like 4 and 7, 4 and 8. So we may need to drop that a little bit. And if we don't have ROSC within 5 minutes, then American Heart and everybody recommends a perimortem C-section. So if you don't have ROSC in 5 minutes, then we're probably going to be delivering that baby. That's only 2 rounds of CPR, which happens really, really quickly. And if you think about it too, when a mom's in the critical care unit and experiences cardiac arrest, one of the highest priorities is also immediately notifying the obstetric and the neonatal partners, because I don't know of any institution where neonatal ICU and OB are close to the critical care unit.
Correct.
Like on the other side of way far.
Sometimes they're in different buildings. Sometimes they're across the street.
Right.
Yeah, sometimes they're across the street. So you really want to give those times. You really want to notify those teams immediately so that you can mobilize those resources and they have time to run wherever they have to run and get to you to help.
So within 5 minutes, baby needs to come out.
So within 5 minutes, the baby should come out if there's not ROSC within 5 minutes. Yep. At that point in time, that uterine environment is very toxic. And so the baby needs to come out. The baby actually will do better being supported by neonatal. And
Mhm.
moms usually tend to do better too, because you've gotten rid of that stress on her body of trying to support not only her own life, but the life of her fetus as well.
Okay, now the baby's out. Okay, we're gonna put our
Hey!
hypothetical. Baby's out, right? Patient's still in the ICU, baby's out. So what happens postpartum? Because like the baby still needs bonding skin to skin. Clearly, I don't have children, but I hear that skin to skin contact's
Yeah.
kind of cool and a big deal. But if your baby's in the mom's in the ICU, baby's maybe in neonatal, like what are we advocating for from like a nursing perspective?
I'm so glad you mentioned skin to skin and know about skin to skin, because it is so important. It helps prevent infant heat loss. It helps them maintain a stable temperature, a stable glucose level, respiratory rate, oxygenation. Like babies benefit from skin to skin, and so do moms. And it promotes so much attachment and bonding. And it's actually very evidence based. So we love evidence based interventions, and skin to skin contact is one of those evidence based interventions. And it can be so challenging because you have a mom or a baby who are physiologically unstable. Most of the time, there's a lot of physical separation between the neonatal ICU and the adult ICU.
Mhm.
So much technology can get in the way. And unfortunately, sometimes I think we as nurses can be a barrier as well, because it's hard.
I was thinking about all the cords and like, your
Yep.
patient's on a monitor, your baby's on a monitor. Like, there's not a lot of skin. Like you really got to advocate to make that happen.
You really have to advocate. I agree. But
Yeah,
that can also be moved or
moved.
changed,
Yeah.
even temporarily. If it's an electrode, to move it. And most people think of skin to skin as right here on the chest, but it can be on the side. It can be,
Oh,
wherever you can find. And babies are little. They're little. They don't take up a lot of room, and they're still in that little fetal position, so
I
they
didn't think
don't take
about
up a lot of
that.
room. Yeah. But to me, this is one of the ways that we can have the biggest influence, because as critical care nurses, we do hard things. We walk patients on the vent. We walk them when they're on ECMO. We walk them with devices. And so even though that whole maternal infant, getting them together, physically together, is hard, we can do it. It's just one more hard thing that we do. So it's really a conversation with neonatal about how physiologically stable is the baby? How physiologically stable is the mom? Who can easily travel better? Let's figure it out. At first, it's probably neonatal bringing the baby over. And as the mom gets better, then it's us bringing the mom over. So whatever's going to work out best. But absolutely, that contact is so important for both the mom and her infant. Yeah.
So I have a question, Julie. I have to know this. So let's say, mom's intubated and, she's totally sedated or potentially even unconscious on her own without
Yeah.
sedation. And she has no ability to touch the baby. So you could potentially lay it on her chest, but some of that, warmth or, wrapping
Mhm.
your arms around the baby is not necessarily going to happen. Can dad be used instead if need be? That's
There are
still
some,
skin to
yep.
skin.
There are some places that will do that and have dad do some skin to skin. There are still
Mhm.
benefits with the mom. And even if I had the most interesting experience. I had a mom who was intubated and sedated. Um, and um, she started kind of like wigging out, like she was just pulling weird pressures on her vent, and blood pressure was just going crazy. And I was just kind of like, what is going on? And we couldn't none of us could really figure it out. And I finally said, let's bring the baby over. And so told the mom, we're getting your baby. It's okay. Hang in there. It's okay. Brought the baby over, pulled everything off her chest. She was not conscious to know that the baby was there. But I tell you, the minute we put her baby on her
Oh,
chest, everything,
she missed her baby.
she
Oh,
missed her baby.
oh,
She knew, she couldn't
yeah.
communicate it, but
Oh,
Mhm.
physiologically she knew. And she was beautiful. And the baby, so the baby was there for like 15, 20 minutes. The neonatal nurse was like, well, they're starting to get a little cool, so we really need to get them back in the isolette. I'm like, okay, that's fine. And this became a very repetitive pattern every 2 or 3 hours. And we started
Wow.
recognizing as soon as she starts kind of like wigging out, it's just baby intervention time. That's all there is to it. This went
Wow.
on for several days because she had severe respiratory disease and really required a lot of support from a mechanical ventilation perspective. And we just started calling it was baby therapy. And she did great once we got baby therapy going. It made her whole clinical course turn around, and she improved, and we got her extubated, and yeah,
Incredible.
it
What,
was
like, what
incredible.
about, like, I mean, I guess you can't breastfeed, can you? Like, if you're on
Oh,
all the other meds,
absolutely.
like,
Well, she may, maybe the
I
mom,
mean, she can,
but it's
but
really important that we work with our OB partners, talk to the postpartum nurses. They will get you set up for success because pumping needs to happen immediately. And actually, pumping is very beneficial for uterine contraction as well. So it helps reduce postpartum bleeding and helps reduce risk of postpartum hemorrhage. So getting that uterus contracted down, pumping is actually really essential because it produces that oxytocin release. So getting that pumping going and keeping it going every 2 hours is absolutely essential. One of the things you want to talk about and think about is that in the hospital, breast milk is considered a specimen.
wow.
Sometimes you have
I'm
to
like,
think about that, but it's a
yeah,
bodily fluid, and all bodily fluids in the hospital are considered specimens.
yeah. I was like, your
So,
urine. Yeah.
right,
Wow.
yeah, it's a bodily fluid. So there should be some very specific guidelines about labeling, storage, and so forth. And you really want to work with your pharmacy partners because the decision will have to be made. What do we do with that breast milk based on the medications that the mom's on? It may be okay for the baby. It may not be okay for the baby. So collaborating with pharmacy is going to be really important.
And lactation.
Yes, and lactation consultants are your best friends. Oh my stars, they're fabulous people. They can make anything work. They can make anything work. Yeah. So those things are really important from a postpartum perspective. The other thing that's really important postpartum is watching that lochial flow. So
I
because
was like,
they're really crazy.
I don't even know what word you just said. What?
Oh,
Who?
so the lochial flow is the shedding of that uterine lining that happens after
Okay.
delivery.
Fun. Okay.
Yes. So a pad an hour is bad. If they are saturating a pad an hour, that is a sign of postpartum hemorrhage. That needs some activation. Or if there are clots bigger than a quarter, absolutely, absolutely raise the red flags about that. So if it's a pad an hour or clots bigger than a quarter, those require immediate notification of your OB colleagues because something is going on and that woman is going to start bordering on postpartum hemorrhage.
I think depending on where you work too, oftentimes the labor and delivery nurses are going to stay with you for a while, right? Until
Yeah,
things get stable because they know you're not the expert in that.
absolutely.
And I think one thing sometimes we fail to do, and maybe in smaller centers that are not high volume delivery places, right? Um, we tend to dismiss things we don't think are important, right?
Right.
So you brought up a really good point just now that I had never thought of. I think inherently I knew it, but it was never on the surface, which was, you know, the pumping right away. Well, when we have a sick critical care patient, that's the last thing you're thinking about.
Right.
However, when you just mentioned, well, it's good for uterine contraction and this, whether you pump and dump or you pump and keep it, a neonatal unit, they can handle all the milk. They've got fridges and all that to deal with
Yep.
that, but it's not something I ever thought about. We would
Right.
be considering right away the importance of that. And really, it is very important. I think that's a really
Absolutely.
good point. I think I just want people to take away, don't be afraid of this as much as possible because you're not alone. While we just provided a lot of information to people, you have your expert nurses in OB in labor and delivery and neonatal who are going to be there to help you. Now,
Absolutely.
depending on the center, you might not have the 24/7 resources, but they're still a phone call away. And you should feel comfortable reaching out to anybody at any time for help because nobody expects us to be an expert in everything.
Absolutely. And we can't, especially with these obstetric women who are postpartum. We don't know that stuff. And as much as we don't necessarily feel comfortable with the breast milk and the pumping and the local flow, they don't feel comfortable with the art lines and the vents and the drips. So
Yep.
it's very much a collaborative partnership. You have to almost learn to talk the other one's language a little bit.
Mm-hmm.
Say, this is what I'm concerned about, and this is why. So that you can really optimize that mom's experience. I also tell people, putting a breast pump on, if the father is involved and interested and willing to help, that's a great job for dad. Like,
Yeah.
Delegate.
absolutely. That's right. That's a
Oh.
great job for dad.
Yeah.
Because it also helps them feel involved and feel like I am
Yes.
doing something and I can contribute, because they are feeling pretty helpless. This was not planned. This was not the way they thought this whole birth experience was going to go. So it is
Mm-hmm.
really challenging from an emotional perspective.
I'm sure that it is for everybody involved because it's really traumatic to see a mom that's intubated and not able to hold her babies or understand what's going
Right.
on. So, it's
Right.
a scary time for all involved, which I think kind of, brings me to this final point, I think, as we wrap up, because it's been great information and so informative. But as we close, we know that many, many ICU nurses rarely care for pregnant patients, especially in low volume centers.
Absolutely.
And so they feel very unsure or unprepared when that situation arises. So, if there was one key message that you would have for the nurses about these pregnant patients, what would it be?
Yeah, we have only scratched the tip of the iceberg. There's so much that we could talk about, um, with very specific disease states, and so forth. I always go back to my three P's: understanding and really thinking about, remember those physiologic changes and the impact they're going to have on the labs, on your assessment, on your plan of care. If your patient's mechanically ventilated, think about, oh yeah, but it's a mild respiratory alkalosis. We always, alter our vent settings according to gases. Well, gases are different. Um, So it's really keeping those in the forefront of your mind when you're working with that patient. Establishing those partnerships, those we've talked about it over and over again, so critically important. And there's so many varied partnerships that you may need. We talked about OB and neonatal and anesthesia, but in pharmacy, but rehab services and dietary and spiritual care is another one that's very important. Sometimes there's a lot of grief and loss that goes along with these situations as well. And that's a whole nother bailiwick that we do not have time to talk about today. But those services are going to provide essential support and consult so that we can really optimize the situation as much as possible. And then know what that plan is, know what those priorities are. Your role as that critical care nurse, as you are that coordinator of care. And that role is so essential to really to ensure that all of those varied services and specialties are aware of that collaborative patient-centered plan. Like, we know this is what's going to happen. We know where and who our resources are. Um, I I just think that that's so essential. Um, to me, critical illness and pregnancy seem kind of dichotomous, like they shouldn't happen together. But unfortunately, sometimes they intersect. And I just think we have such a unique opportunity to positively impact the mom, her child, the whole family during this very typically unexpected and probably undesired situation. I think that critical care OB patients are some of the most challenging patients, but they can also be some of the most rewarding situations.
Oh, Julie, I feel like we could talk for days on all of this good stuff. I feel like you said, we only touched the surface,
Oh
but
yeah,
you know,
we can talk for
there's
days.
oh, exactly. There is so much good information you do, but we do need to wrap up here. So we do want to thank you so much for sharing your experience. While having a pregnant patient in the ICU is definitely going to be scary. It sounds like maybe we got a little tips and tricks in here to make it just a little bit easier to deal with. So we want to thank you so much for sharing that information with us.
Well, thank you for having me. This has been really fun.
Yeah, I'd like to second that. It's been great. You are a wealth of knowledge, and I'm sure every nurse who listens is going to say, "Gosh, I wish we had one of Julie in our organization." So, thank
I
you
don't
for
know
sharing.
everything by any stretch of the imagination, but I do have a passion for making caring for that critically ill obstetric patient just a little less scary, and knowing, okay, I gotta physiology, partnerships, and plan. Those are my three key priorities I have to go to, and hopefully we can all make it better for that patient and their family.
Well, I think you are well on your way.
Thank you.
And as we wrap up, I want to say thank you to our listeners for joining us for this very important conversation on caring for pregnant patients in the ICU. And as always, if you have feedback on this podcast or ideas for future topics, please email podcasts@aacn.org.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's Career Center, offering career resources, free resume reviews, and personalized job alerts, with information available at www.aacn.org/career center.